Topic ya tatu ilitoka kwa ndugu Levocatus ambayo aliongelea masuala ya errors, na kikubwa kabisa kilichoongelewa ilikuwa ni swala zima la components of errors and their respective elements, namna gani ile vitu vinavyounda errors. Pia akaongelea kuhusu developing and implementing of elements of errors on cesarean section so as to minimize complication and to improve patient satisfaction in the setting. Baada ya hapo kulikuwa na maswali mengi yaliyoulizwa kutoka day 1 na day 2, lakini kikubwa ni facilitators wa day 1 na 2 wote walikaa kwa pamoja and maswali yaliulizwa, lakini Dr. Debora alijibu maswali na wengine pia. Kuna jambo lilikuwa what was the cut level of pledges for the same conduct of spinal anesthesia, ambapo tulikubaliana wote tutaondoka na at least isiwe chini ya 70. Sio ikisema ya 70 na maanisha 70. When you want to perform what spinal anesthesia. So ila tujitahidi, atasisitiza swala la kufanya full blood count, lakini pia bleeding and clotting time bedside. Washiriki mbalimbali, mentors wakiuliza maswali. Hawa ni baadhi ya watu waliweza kuuliza maswali. Baada ya hapo tulienda kwenye utaratibu wa chai. Kama tunavyoona ndugu zetu wanajipakulia vizuri, kila mtu yuko serious kuangalia kinachopatikana, na pia baada hapo watu waliketi wakanywa chai vizuri. Lakini kinachofurahisha ni kuona anasema kambi popote, hata kama chai inaendelea, lakini kuna watu wanasalimiana pia na kujuliana hali, sio? Ndugu yetu kutoka Zanzibar hapa naona anasalimiana na mwenyeji wake wa Arusha. Topic ya wellness ilikuwa presented na emphasize ilikuwa ni time balance between work and leisure, kwamba hata kile kidogo tunachokipata basi tuweze ukienjoy. Na hisi pia mwaka jana tulishakiongelea, tukasema kwamba ni vizuri tuweze kutenga muda wa kuenjoy, la sivyo maisha yetu yatazidi kuwa magumu. Ukitaka kuamini kwamba unaweza kuwa replaced, hebu umwa au upata matatizo, ondoka. Utakuta hospitali iko pale pale, huduma zinaendelea. Alternative, kwa hiyo wewe sio solution wa kila kitu. So create time for your own time, enjoy life. Kingine kilichoongelewa ni time for good family and refreshments. Familia ni jambo la msingi. Nasema charity begins at home, sio? Kwa hiyo tuanzie nyumbani. Also staff motivation for overtime works. Usitegemee sana vitu vya nje vikupe motivation. Sometimes you have to have your own inner motivation. So you have intra motivation and intra. Anesthesia, kulikuwa na maswali mengi kidogo hapa, lakini swala zima liliongelewa ni kuhusiana na performance of new technique of spinal anesthesia using low dose, low volume and slow injection so as to achieve the unilateral block, which is specifically for unilateral lower limb surgery. Kwa hiyo tulijadili na wengi waliuliza maswali, naamini at least tumepata kitu kingine. Baada ya hapo tuliongelea kuhusu masuala ya palliative care. Emphasis kubwa ilikuwa ni kwamba tujitahidi kila tunavyoweza tusiwapeleke wagonjwa wetu kwenye palliative care. Yaani panga panguo, jitahidi fanya kazi yako kwa weledi, uhakikishe kwamba umemtoa mgonjwa vizuri, na hata kama unafanya referral basi ufanye referral ambayo iko kweli ni referral, ili yule mtu aweze kupata huduma. Sikae na mtu akaenda point B unasikia amekufa, hata wewe mwenyewe unajisikia vibaya. Kwa hiyo tusishiriki kwenye kuwapeleka watu kwenye dialysis na mambo mengi. Kwa hiyo tufanye kazi zetu kwa weledi kama anesthetist. Hakikisha tunafanya pre, intra and post assessment ili kuweza kujua hali za wagonjwa wetu. Also, best knowing how to offer sedation and analgesia for patients who require invasive procedures as part of palliative care. Sana anesthesia role kubwa sisi ni pain management. Kwa tujitahidi modalities zote za pain management tuweze kuzifanya. Alafu kingine tulichotoka tulienda kupata lunch. Hapa kwenye lunch tunaona sio sisi tu, masista nao wanaenjoy kidogo, ndugu zetu tulionao wanapanga mstari kidogo, wanang'ang'ana kuweka tuko sawa kabisa. Basi watu wanaendelea kupata lunch na pia wakiwa wana socialize. Ndio hicho kitu tunachohitaji. Tunatoka huko tulipo, tunabadilishana mawazo, tunajuana. So hapa naona kuna sijui Kiingereza kilikuwa kinaendelea. Sasa sijajua hawa waliokaa ila walielewa au kwa sababu walikuwa nakula na mimi walielewa. Hapa naamini huyu alikuwa anaelekeza vizuri kwamba umeelewa. Je, ratiba leo siku ya 3 DB unaiona? Uko tayari? Naamini anielewa somo, si ndio? MC unasemaje hapa? Utakuwa nielewa.
Hapa hajaelewa pengine kabisa.
Basi baada ya hapo ndio ratiba ya kwetu walikuwa naonyesha kwamba kesho ni day 3. Kwa hiyo wale mapema presentations za kwepo zinamiminika. Basi MC naona hajafika, lakini kwa hivyo asante sana.
Hapo nimepigwa. Au mnasemaje? Hapo nimepigwa. Mnasemaje kwa rekefu ya jana? Wangapi wamefurahia? Tafadhali punga na hii. Oh wow. Naomba niseme makofi mengi kwa presenter wetu. Ila sisi tulifurahia ile goli moja tu. Maana jamaa alikuwa anakaribia clean sheet za kushinda. Sasa goli moja sisi umetusaidia kitu. Sawa? Baada ya kusema hayo, asante sana kaka Aston kwa presentation nzuri ambayo ni njema kabisa. Mungu akubariki sana. Makofi ya toshi. Naomba tukae. Have a seat.
My name is Mike Vegan. I work in Dublin. I'm an anesthesiologist in a clinic called the Black Rock Clinic. We do a lot of cardiac and thoracics. It's not an obstetric clinic. My main fields are thoracics and orthopedics, but I have done a lot of maternity in the past. So just about the anatomy and physiology changes in pregnancy, it's important to recap that. I think that there's a lot of changes when a woman gets pregnant, and those advance as the trimesters pass and as the baby gets bigger. So pregnant women are at higher risk of aspiration, like pethidine, and also they have acidity increase in their gastric acid is increased, and acidity, the pH is lower. So then the other regarding general anesthesia, they have a rapid onset of hypoxemia at induction because they have the gravid uterus compressing the lungs. They also have the metabolic load of the fetus consuming oxygen. So the FRC is decreased by 20%, and oxygen consumption is increased by 25%, up to 60% in some patients. There can be difficulty inserting a laryngoscope blade. They have enlarged breasts. There's often weight gain in pregnancy, and because of the weight gain and large breasts, there can often be difficulty inserting the laryngoscope, but also difficulty getting a good view of the cords at laryngoscopy. They're all areas also more prone to bleeding, so multiple attempts at intubation or airway manipulation can result in bleeding. This is especially important in patients with coagulopathies or preeclamptic patients with higher vascular growth in the airways. So neuro, just as an overview, most cesarean sections, as you know, are done by neuroaxial technique. It's largely overtaken GAs. There was a tendency towards GA in the 80s because of reports of local anesthetic toxicity. So some countries were slow to move on to spinal anesthesia for cesarean section, like our colleague alluded to in Kenya in the 80s. But there's been a steady decline in GA cesarean sections. In the US, it was 35% of cesarean sections in 1981, and in 2011 they only account for 25% of cesarean sections, and the vast majority of those are emergency category 1 sections which means there's an immediate life threat to the mother or the fetus, and you don't have time for a spinal. 2.3 per 100,000 of GAs, compared to the general population, which is 1 in 180,000. So higher, significantly higher. Anesthesia-related maternal deaths still accounts for 1.6 of all maternal deaths. And it's important to recognize that airway changes, even though you've pre-assessed the patient maybe a few days before, they can change. The airway can change, especially during labor. The malempathy score can increase from a 2 to a 3. It can be edema in the airway. So it's important to keep that in mind. That it's actually tracheal extubation and management of the airway is very important, especially if it was a difficult intubation. And from a Michigan study looking at an 18-year period where they had 8 maternal deaths from airway issues, 5 of them were in the post-intubation period after cesarean section had taken place. So what evidence do we have that the obstetric airway is difficult? We all think it's difficult, here's just some papers that have different, they cite different incidents. There's a large variety. So the BJA, a big study in the BJA, assessed it at 1 in 180. Then the South African study assessed it at 1 in 71 incidents of failed intubation. And an American study assessed it at 1 in 312. So are obstetric patients really more difficult to intubate, or it's been cited that the incidence of a difficult airway is 8 times higher in obstetric patients. But is this really down to specifically the airway changes, or the stressful environment, or the experience of the anesthetist, or the stress the anesthetist feels when intubating a patient, and this kind of nihilistic feeling that something could go wrong to the mother or fetus? Everything is rushed, and it's the proper pre-op preparation is not done properly. So factors that contribute to difficult airway management or any airway management is patient factors that are very important, obviously. Anesthetists, the experience of the anesthetist, their experience in obstetric practice, the equipment available, whether you have a range of laryngoscopes, whether the anesthetist is versed in using different types of laryngoscopes, and also supraglottic devices, and the situation as well. How urgent is the section? So I'll just rush through that. So we obstetric patients at term going for a cesarean section only rapid sequence induction because of the high risk of aspiration. And preparation, positioning, and pre-oxygenation, one should always keep in mind the 3 P's of taking a gravid patient in for a cesarean section. So this patient, they must obviously have a good laundry department in their hospital, because she's stacked up in a ramping position with, I don't know how many sheets, but you can either use sheets away from the neck, making it easier to get the laryngoscope blade in, and it also moves the uterus off the base of the lungs, so hopefully pre-oxygenation will be better. So when you're pre-oxygenating the patient, it's important to aim to achieve an FiO2 of 0.9. So that can be achieved in most instances by tight-fitting face mask, 3 minutes of standard respiration. But studies looking at this noted that even with that pre-oxygenation applied in that way, that only 75% of patients reached a FiO2 of 0.9. It's been around a long time. Mendelssohn first described it, but it's undergoing some critique, and it's not quite as rigid as perhaps it used to be. The classic recommendations for rapid sequence induction are pre-oxygenation, suction turned on and under the pillow, confirmed reliable intravenous access. You have to check your IVs before you inject anything in. Field now, we recognize that we should maintain oxygenation during attempted intubation, and that you can actually, with high flow oxygen or even standard nasal probes, you can decrease the incidence of desaturation. That is a threat to the mother, but also very importantly to the fetus. You have to make sure that the patient is completely paralyzed before instrumentation. There can often be a rush to go in very quickly, but you can provoke a gag, and that will provoke regurgitation or aspiration, and then subsequent aspiration. And treatment tube inflation as soon as the tube is in, and before you've instituted pressure ventilation. So these are, these are all the recommended components of what the different airway societies still recommends for rapid sequence induction. Now they suggest other components. As I said, apneic oxygenation, doesn't have to categorically be there in all rapid sequence induction, but it's strongly recommended that if you have it available, you should use it. This probably should be part of the core components of rapid sequence induction, not just a suggestion, but it's the ability to do triangular position if regurgitation occurs. And then there's the question of, do you put in an NG tube or not, and that's open to the clinician. So NG tubes can remove most of the gastric contents. It doesn't remove all of the gastric contents. The problem with NG tubes is it can decompress the stomach, but it also opens the lower and upper esophageal sphincters. So I'll come back to chronic depression. Just a word on apneic oxygenation. So the classic pre-oxygenation you see on the top left, that'll give you in a non-pregnant patient. They haven't done these studies in pregnant patients because of the ethics behind doing that, allowing testing oxygenation in pregnant ladies just would never get ethical approval. So standard for a non-obese patient, 6 minutes. You have, after you put a patient to sleep after pre-oxygenation with a tight-fitting face mask, you'll probably get 6 minutes if they're not septic. They're 6 minutes of saturation of 94. If you use nasal prongs, as we see on the right, you can extend this to 12 minutes. And now if you use high-flow humidified oxygen, which is increasingly available since COVID especially, you can extend the period of apneic oxygenation during laryngoscopy by 45 minutes. Obviously, if you're struggling with the airway that long, you have to remember to inject propofol because you're not ventilating the patient, or switch to back mask ventilation. But it just goes to show you how long you can keep a patient apneic. So the Airway Society have moved from the term pre-oxygenation to per-oxygenation in obstetrics. So pre-oxygenation we all understand, but they've added in apneic oxygenation to the definition to make per-oxygenation. So it just reminds us that do your pre-oxygenation and keep the oxygen going during attempted intubations. Apneic oxygenation is very effective. It's easy to use if you have it available. But you can't measure end-tidal O2 as you can with face mask ventilation. There have been some research outside of obstetric anesthesia to try and move forward to not do mask pre-oxygenation, but just have high flow from the beginning. But it has shown not to be as effective as doing a mask, good mask pre-oxygenation, and then keeping the nasal prongs on. So, intubation of an obstetric patient will depend on your equipment available. There's been a lot of research comparing direct laryngoscopy to video laryngoscopy. Some anesthetists bodies were very slow to move to video laryngoscopy because they felt, you have to be tough, that's our airway, you have to struggle with the airway, because there was a bit of a macho attitude to it, and video laryngoscopy makes it a bit too easy, and we don't look as impressive as we once did. But ED doctors moved to video laryngoscopy. ICU doctors, largely, at least in Ireland, have moved to video laryngoscopy. So anesthesia was somewhat left behind, but since COVID, there was recommendations to video laryngoscopy for all COVID patients, because you can be further away from the airway, so less chance for the operator to get inhale aerosolized COVID. In a study comparing video laryngoscopy with direct laryngoscopy, the first pass success actually was slightly higher at 84% versus 79% for direct laryngoscopy. So not actually a big difference, but you'd have to look at the experience of the operators and what kind of patients they were. But there's 3,000 critically ill patients who were studied, and it's a large patient body, and that was the outcome. But I'm a big proponent for video laryngoscopy. If you have it available, try and use it. Use it on routine, non-obese, non-difficult airway patients first, just to get used to it, and then you'll be more able to use it in an emergency situation. These are just further studies comparing them. So video laryngoscopy has been shown to reduce rates of failed intubation, higher rates of first pass success, and improve glottic view. However, although it can improve glottic view, there can be a few problems with it. There's a thing called glottic impersonation, where this is a picture on the screen of a video laryngoscope, whereas if you advance the screen, the laryngoscope blade and with significant force up against the glottis, you and pull anteriorly, you get a good view of the epiglottis, of the esophagus below. So because it has this blanching kind of structure, because you're forcing, using quite much force, you just have to be wary that sometimes you get a view of two holes, and just know your anatomy of the vocal cords and the glottis to be sure that that's where your tube is going. It's important, the picture on the right, to end-tidal capnography. Once you've secured your tube, even if you're sure that it's gone into the esophagus, there can be, on the right, we see a successful tracheal intubation. That's a good capnography curve. You know the top hats where expiration is on the upstroke, and then the plateau, and then inspiration. That's in a healthy patient. But if a patient who's bleeding or hypovolemic is unstable, it can present differently. You don't always get these clear cut top hat appearances on the capnography. Below in red, you see that esophageal intubation. That's esophageal intubation. It can be quite similar to a patient with an intubation in the trachea. So you use capnography, don't rely on it completely. Always do your auscultation as well. And keep in mind that if the patient's status is deteriorating, even though you think you have a good capnography trace, always look inside again and think, could this be in the esophagus? That's another picture of esophageal glottic impersonation. And it's probably more likely in a stressful situation like a category 1 C-section. Due to stress induced, sometimes we can get into this false sense of security. Oh, it must be in, it can't not be in. So you're lulled into it. Oh, the tube is in. It looks like it's condensing. Crack on with surgery. but you really have to secure, make sure the airway is in the right place before proceeding to surgery. It can be critical complications if you don't. This is just saying identify anatomical structures to make sure this doesn't happen if you're not sure. So you identify the glottis and the posterior aspects of the folds. Another advantage of video laryngoscopy is that, especially if there's an external monitor, it kind of be a joint effort, so it kind of shares the stress load, and it's not so one operator dependent. So the recommendations of the airway societies are that video laryngoscopes are recommended whenever feasible, but obviously it depends on availability. So in obstetric, this is the guideline for obstetric general anesthesia and failed intubation. You've done the first box, pre-induction planning and preparation, rapid sequence induction, then you go for laryngoscopy. The recommendation is that you have 2 attempts at intubation and no more, and then the third attempt should only be made by the most experienced clinician around. Several attempts can result in bleeding and swelling of the vocal cords and complete obstruction of vocal cords. Repeated attempts, especially using succinylthonium as well, can lead to laryngospasm. That the succinylthonium wears off, particularly in a bad view, you're poking blindly. Leads to laryngospasm, patient desaturates then, and then you go to ventilate the patient and you think you're in a can't intubate, can't ventilate scenario when actually in fact the succinylthonium has just worn off and it causes laryngospasm. So there have been cases of that where patients have had cricothyrotomies because they used to thought they were in a laryngospasm and couldn't ventilate them. So if you're still failing and the most experienced anesthetist has failed as well, you have to declare a failed intubation. Call for help and maintain oxygenation then becomes the priority. And this is best done with a supraglottic airway device. You often have a leak if you follow the right weight-based suggestions, and they're second generation because they have a little port that sits over the esophagus where you can pass an NG tube through, or if you don't pass an NG tube through, if there's ever air build-up in the stomach, it will pass through that little port in the igel anyway. So then you're in a situation where if you still can't ventilate a patient with the supraglottic airway device, and the patient is fully paralyzed, then you have to declare a can't intubate, can't oxygenate situation. And the recommendations are that you don't wait for desaturation. If you've had all your best attempts at intubation, bag mask ventilation, and a supraglottic airway device, and the patient is still saturating, don't just keep trying the same things. If it's not working, go on to frontal neck access before the patient starts desaturating, because frontal neck access takes a considerable amount of time, and time is of the essence. It's easier said than done, to go to frontal neck access in a patient whose stats are still like 94 or 95. I don't think many of us would do it. So just a word on supraglottic airway devices. As I said, I favor the igel, very easy to insert, you don't have to inflate it, and has an added aspiration risk protection. If you do use an igel, you should remove cricoid pressure when inserting the igel, and then whether you reinstall cricoid pressure is up to you. It's recommended that it's open to the clinician. This is the same again. These are just some different variations of second generation LMAs or igels. This is the port that you can insert a nasogastric tube down. or sits over the esophagus and deflates any buildup of air in the stomach. This is the eye gel, the one I favor. All these others require inflation. The eye gel was invented by, we all know Archie Brain invented the LMA, seminal moment in anesthesia history, saved millions of lives. The eye gel is the next generation. It was invented by a Pakistani doctor called Dr. Nasser, and they call him the Archie Brain of Pakistan. And a nickname that I really think is spot on is a play on the words Archie Brain. They call him Karachi Brain. So cricoid pressure, I think most of us would still apply it in emergency sections. It's come under a bit of criticism, but hasn't been fully disrecommended. So we know 10 newtons increasing to 30 newtons as the patient goes to sleep. How much is 10 newtons when finger blanching first appears, apparently. And just practice, if you're struggling with cricoid pressure, localization, if you're the one intubating, you should be able to guide an assistant how to apply cricoid pressure. So practice on non-obese patients first. So there's the thyroid cartilage, which is the big, the main prominent cartilage in your neck, and then below it you have the cricoid cartilage, and that's the one you press on. Criticisms of cricoid pressure are that it doesn't actually work. When you apply it, the esophagus slips to the side, and they've done MRI studies where they put a patient in where someone is applying cricoid pressure and they notice that the esophagus slips to the side, so it's actually not doing its intended role. It also makes bag mask ventilation more difficult, it makes airway intubation more difficult. Coming under a lot of scrutiny. And if you do decide to use cricoid pressure, just to make sure there's a dedicated individual who has no other responsibilities and knows that that's their job. They're not shouting out instructions at other people. These are basically all you have available beyond on your standard airway. If you're using videolaryngoscopy, a problem with videolaryngoscopy can often be that you have a great view, but the glottis is quite anterior and you can't pass the tube through. Very frustrating, so you can use a bougie, or you can pre-curl the tube before starting. And once you once you visualize the glottis, just undo the tube, and it maintains an amount of curl for a good portion of time, and it overcomes the problem with not being able to get anterior enough. If you fail to intubate with any patient who needs an endotracheal tube coming for an emergency surgery, I would recommend using an eye gel. Good thing about the eye gel is you can pass a bougie through it and the tube through it. So you could pass a bougie through the eye gel and feel for the railroad track sign on to signify that you're in the trachea, and then it's just back mask ventilation. So if you have a patient, this is one question we face, that you can't intubate, but you can oxygenate, whether it be by supraglottic device or back mask ventilation, what do? You wake the patient up, and this is a table that recommends a course of action. They're not fixed guidelines. So I'll just run through them quickly. So you look at the maternal condition first. If there's no compromise, wake her up. If mom is fine, if she's not hemorrhaging, wake her up. Then the suggestion to proceed steadily increases the recommendation to proceed as the mother's condition deteriorates. So obviously if a woman is near the arrest and you can't intubate, but you can put in an eye gel, just the recommendation would be crack on. Second condition we look at is fetal condition. If there's no compromise, wake the pet mother up. Obesity is another factor to look at. Surgical factors, aspiration risk. So an interesting table to have in mind if you're faced with that. Which green is good, you have the patient well oxygenated and breathing spontaneously. As soon as you put the patient to sleep, give muscle relaxant, they're no longer breathing. So you're heading, you have to secure one of these airways, either tube, LMA, or face mask. And down at the bottom here is cricothyroidotomy. So you should always aim to get back to the high ends of the blue or the green. If you do need frontal access, the airway societies now recommend using equipment that you recognize, not specific cricothyroidotomy sets, but bougie scalpel technique, where you make an incision, you make a transverse incision, and then a horizontal incision. You rotate the scalpel through 90 degrees, pass a bougie that's loaded with a tube, like 6 tube, and then pass it in hopefully. There's a thing called the laryngeal handshake to identify the spot. You start up high in the neck, grabbing the under the chin, and work your way down to identify the red spot. Airway complications after surgery are very important to look out for. Look for difficulty breathing, stridor. Don't just forget the patient on the ward or in the HDU or ICU. If it's been a difficult intubation, look out for swelling at the end. If you have a video laryngoscope, especially, you can look for swelling of the cords. Do a cuff deflation test before extubating. Deflate the cuff and look for a leak. If there's no leak, you probably advise to keep the patient intubated for a period of time, just until you get a leak. So just in summary, it's time to probably re-look into the narrative about obstetric airways. They're probably not as hard as we think. Stress plays a big factor. Video laryngoscopy is mask ventilation, post-induction. This is increasingly being recommended. Traditionally, we never were advised to bag mask ventilation a patient, but now it's somewhat recommended, but open to the discretion of the operator. And that's know your plan B. All right, and don't forget the basics. Thank you very much.
Thank you.